Oh.
I guess we can start talking. This sounds... Okay, hi. I guess we're waiting for some people to show up. But let me introduce myself. I'm Alberto Marchevsky. I'm a native of Mendoza, Argentina, the land of the good sun and perfect wine. But now I work in California at the Sinai Medical Center, which is a large private academic medical center, where I served for years as director of AP. Now I'm the director of thoracic pathology. We also teach at UCLA, where I'm a clinical professor. I have been a proud member of AMR for many years. And I was thinking when I heard about this meeting, that I should start looking for cases to show. No? And I usually show thoracic cases, of course. But then I got an interesting email from Suster. I'm supposed to talk about historical perspective and evolution of our specialty during your long career. And I said, oh my God. I don't know how it works in your country, no? When in California somebody tells you that, it's over. My God, you are the oldest guy in the room, your time is up, when is your retirement party? So then I have a problem, how should I present the lecture? What should I say? I thought, well, maybe I can give anecdotes about this or that, trying to transmit so-called wisdom to younger people. But I tried that with my residents, and usually I get one question. Dr. Marchevsky, when are you going to retire? So I basically smile and be very polite. But I feel like saying that, have you seen the latest scientific videos on TikTok about the advances in artificial intelligence? When are you going to be replaced by a computer and retire yourself? No? Well, of course, you cannot say that in this day and age. I would get fired for being antisocial. Okay, so I tried to combine in the lecture the past and the present using this unusual feature. So the way I organize the lecture is you'll indulge me on a brief remembrance of my career in pathology in the last 50 years. They will describe the evolution of clinical pathologic entities. We'll look at how certain technologies like IHC basically changed the field. I'll give you a few examples of other technologies that were very popular and then disappeared. I'll describe basic concepts of evidence-based medicine, which has been one of my interests. And when I do that, I'm sure I'm going to sound like a pain in the neck, because I seem to be criticizing practicing pathologists and the fact that they study tumors with specific meds, but that's really not the intention, as I'm a card-carrying practicing pathologist. And then we'll elaborate on the concept that history does not repeat itself, but often rhymes. So some of the things we've seen in the past seem to be coming in slightly different shape nowadays. Okay, so I did my residency in the mid-1970s. And at that time, there were still dinosaurs in the medical environment in the US. And it was completely different now. Doctors were in charge of hospitals. The pathology chairmen basically were very good pathologists that were selected because they were the best in the field. And they ran the place like an autocrat. Whatever they said was the law. Surgeons were very energetic people that used to scream at everybody. And pathologists didn't have such a large status. Most medical students were willing to work very long hours, very hard, to get into a surgical specialty, another specialty where they could join a private practice and then make a lot of money and obtain a high social status. So that was good for me, because basically opened up the door to foreign graduates to join very good programs in pathology. So I was basically lucky to be able to get a position at the Children's Hospital in Boston, and then moved to New York. And at that time, basically, there were autopsies. I heard you heard the word autopsy. We don't do them very often nowadays. And I think what I think is the area of intellectual giants in pathology. There was no sub-specialization whatsoever. So these were the giants during my training, and you don't know this, so it don't mean anything to you. But I couldn't give a lecture without acknowledging Dr. Gordon Potter, was a professor at Harvard and the chief at Children's. And I really appreciate him because he was a guy that gave me the opportunity to get a position in a good hospital. Then I moved to Mount Sinai, where Dr. Stephen Geller was the acting chair, and that was my boss in California for many years. There was Dr. Kleineman, was a pulmonary pathologist who became the chairman and then sort of got me into pulmonary pathology. Dr. Popper was there, but was semi-retired. He was a giant of liver pathology. And then the person I learned the most surgical pathology was the chief of surgical path, Dr. Mamoru Kaneko. And I think training at Mount Sinai was almost like joining the Marines. It was a little different than the residency now, where residents are supposed to work a certain number of hours and follow certain guidelines. And we are supposed to treat them very gingerly and so forth. There we had gross inspections every day. So you were supposed to sign out, no excuse. They would show all the interesting cases of the day, and you were expected to make diagnosis grossly. And then Dr. Kaneko was able to do that most of the time, so you were expected to do the same thing. There was no sub-specialization, but in reality there were fewer diagnoses to choose from. At that time when you read this book by Dr. Rosai, basically you could learn all pathology. Now you couldn't do that because there are too many subtitles and so forth. The motto there was that we're not supposed to read books, look at slides, that you learn by looking at actual cases. And ironically, that's become the rule now because our residents never read books. They look at the path outlines in the computer. All the residents were given by, all the pamphlets given by residents. And it was a terrifying experience because all the bosses would sit in the first row and they would criticize everything you said. You were mentioned, this cell looks really, it has a high acid ratio. Where is the cell? The patient died. Oh, why did the patient die? You start giving an explanation. No, give me the cause of death. So the emphasis was on being very factual. So basically, we are trying to be able to recognize the very small details and being very factual and try not to be too academic in the sense of making up information. When we were to make diagnosis, we were very simple. Diagnose tumor, size, margin, invasion, case over. So it's very different from what we do that. I was lucky because there were very few stains. And we were supposed to be very fast. All the cases were signed out basically one day. So during that time, basically, like in the Marines, that ingrained in your brain certain routines. So basically, you don't jump to high power. You look at gross, look at the spacing at low power. You didn't make the diagnosis, then you are in trouble. And then you go up into higher power progressively. And then we were supposed to write diagnosis in a very concise manner. Organ diagnosis, sometimes mention pertinent negatives, and very rarely comment. And then an advice was basically not to think about too much, because then when you overthink diagnosis, you end up being confused. In fact, Dr. Kaneko had the same sort of joke. The people that were too intelligent and did too much research were not good pathologists. They thought too much. So this is an example, and this sort of stuck in my mind. This is a recent case I had at Cedar Sinai of an explant of a patient with UIP. Diagnosis, lung, UIP, I mentioned the organs, took a few photos, case over. Yeah. This is a case, identical case, signed out by one of my colleagues, who is a very good pathologist trained at Mayo Clinic. Very long description. I guess they have a different format there. And apparently he has some belief in one of the mathematical formulas that I've developed over the years, that the length of a diagnosis is inversely proportional to your understanding of the case. When you start writing too much, means that you exactly understand what's going on. So let me go now to the environment of pathology in the 1970s and 80s. Pathology at that time was sort of transitioning from the study of disease, mostly with autopsy, where people were trying to understand how disease developed, why people died, what was the result of treatment, into surgical pathology that was sort of invented in the US. And basically, people started describing clinical pathologic entities. And how you did that, basically, you collected a small group of cases, you found the morphologic features, you look at the survival in terms of overall survival, and you found P05, you have your entity. And everybody was fighting to invent a new entity. But then, of course, there are some problems I'm going to briefly discuss. And based on that, people issue recommendations. For example, patients with lobular carcinoma in situ often have invasive carcinoma. They tend to be bilateral, so surgeons should do bilateral mastectomies for LCIS, without really doing any studies and so forth. So it was not entirely scientific. Dr. Rosai, who was one of the giants of pathology at the time, even though he was kind of short, wrote this book of American history of American surgical pathology and titled it Guiding the Surgeon's Hand. So everything was designed to do surgery. At that time, pathology had many gods, no? That basically they ruled the field. So you didn't need the WHO to issue a classification. You had Dr. Enzinger wrote a paper on particular soft tissue tumors. Everybody would use his classification. Same thing with Dr. Scali for GYN and Dr. Rosai for thoracic tumors and other things. Looking back, there was really minimal introspection about the clinical validity of this general approach. For example, there's a lot of inter-observer variability when you look at histopathologic features. Not everybody agrees on the findings, and then some people give more weight to one finding than the other. So these overlapping findings. People were using overall survival, which is really not a very good endpoint, and we still do it in current cases. But everybody dies. No? So how do you know if they die of the entity you're describing, or they were hit by a car, or they had a heart attack? And if you're older, are much more likely to die than you're a young person. So all these things are not being considered in the statistics. The other issue that was never considered, and which is still ignored by most papers, is that when you find a retrospective correlation between findings and prognosis, you find P05, makes you feel good. But that doesn't predict the future. No? The statistics for prediction are completely different than for the past. Otherwise, you could do a study of Las Vegas, who is going to win in the casino, you do your statistics, and then that will not predict who will win or not. No? This variability in everything led to the conflict which is still seen even today between lumpers and splitters. And of course, splitters won. Why? Because everybody wants to publish a paper. It's the only way to become a professor. And the more you publish, the more, and then you can get your entity into now the WHO, you're a winner. So in the late 70s, immunohistochemistry was introduced as a method that could be used in paraffin blobs. And that really revolutionized pathology. Up to that time, basically, the chief or the experienced pathologist was always right. They would tell you, don't worry, I've done this 100 times, I know the diagnosis. But then when people started doing immunostains, things became more complex. The chief would say, oh, this looks like a large cell lymphoma. It's keratin positive. It's not a lymphoma. Then it started creating a conflict between immuno. So of course, that created a revolution in pathology. The most famous paper at the time was one by Dr. Fletcher, where he showed that what we used to call malignant fibrocystoma, that was a tumor described by Dr. Enzinger, who was a pope of soft tissue pathology. And the dictum at that time was that half of the sarcomas were malignant fibrocystoma. And then comes this young guy from England, and they show that when you start doing immunostains, most of them stay like something else. So malignant fibrocystoma practically has disappeared from routine diagnosis, except some of the rare cases we've seen in the conference. So once IXD appeared, everybody was very excited. Basically, now we can diagnose cases very precisely using immunostains. Then new antibodies were described. Everybody wanted to have their own antibody as the first person to use it. You would go to IAT conference, ask Capcom, all the papers were on spatial stains. So there was a concept that the more stains you do, the better, the more you're going precise. Which is not very unlike what we see now with methylation and molecular and so forth. That's supposed to solve all our problems. But the reality was a bit more complex. Antibodies were tried by different laboratories and they got sometimes different results. There were more than one antibody against the same epitope and results were not always the same. And then there was a problem of interpretation. Do you call it positive when it's one cell, 5% of the cells, 10% of the cells? Is that really positive or not? And that creates variability among pathologists. And it sort of led that IHC may not be the perfect tool to make diagnoses. Now I joke with the residents that IHC is a method designed to provide comfort and discomfort. Comfort, you think you know the diagnosis, you do the stains that show you that right, you feel comfortable. You know the diagnosis, or you think you know the diagnosis, you do stains, you don't know why they're positive, you're uncomfortable. Eventually you tend to disregard them. And I think the evolution of this is shown in this small example of a classification of lung cancer. We used to call them non-small cell carcinoma, large cell carcinoma. Then people developed TTF1. And the original paper said, well, you do TTF1 in lung carcinomas, and then about 75% of adenocarcinoma are positive, 25% negative, which I think is still true. But then 15% of squamous cell carcinoma are positive. Then people say, oh, what do I do with this? Then they have, well, maybe I should call a tumor that has this, I call it tumor that has adenocarcinoma immunoprofile, rather than using just immunostain. Other people say, well, just cut to the chase and call it adenocarcinoma. Then we start calling everything with TTF1 adenocarcinoma. Then people say, oh, some tumors that are not adenocarcinoma, like large cell adenocarcinoma, are also TTF1 positive. So this is going in somewhat circular manner. So at the WHO, and I had the privilege of attending some of their sessions, there were big discussions of where to use immuno as part of the diagnostic criteria. And I think they're still arguing about it because of these technical problems. The immunostains create problems. For example, you look at a tumor that looks pink, you think you're seeing intercellular breaches, you think it looks like it's squamous cell carcinoma, and then it stains with TTF1. What do you do? Nowadays, I think the trend would be to use the immunostain in that sense. But is that adenocarcinoma diagnosed as such, even though it looks like it's squamous and H&E, the same adenocarcinoma that we called before? There are really no studies showing whether it's the same entity or not. I don't think anybody's going to do the study because it's propelled in a somewhat confusing manner. When you do immunostains, you have to understand the original concept that the more the better is not necessarily true. And I think that may prove for some of the current molecular methods. And it's a matter of mathematics. Basically, you do a study, how you're going to do it. You have tumor A, tumor B. You do the antibody. It's very rare that you will get 100% specificity. Let's say you get a good, for simplicity, you get 80% specificity. That would be a probability of 0.8. You use a second antibody with the same probability of success, but your result is lower. Because when you multiply probability, it gets down to 0.64. The more you stain, the more possibilities of getting confusing results. So I think the way we teach our residents is that you should formulate a differential diagnosis on H&E and then apply immunostains that basically will help you distinguish A from B from C. Unfortunately, that doesn't work all the time. Sometimes you have to use what we call a shotgun approach, where you stain everything in the book. But in most of those cases, you can never make a diagnosis anyway. So I think we teach them to select as few as possible immunostains. And I think you have to think a bit like a lawyer. You know, lawyers basically don't ask a question that they don't know the answer, because they could be tricked in court. So basically, you order an immunostain, it's a good idea to know what you are going to interpret if positive and negative. Otherwise, it's not a good idea to order the stain because you'll end up being very confused. Beyond the immunohistochemistry, there were other techniques that were very popular and then disappeared. One of them is electron microscopy, that I don't mention in the Kodak. But at the time I was finishing my training, everyone was doing DNA cytometry. You would go to the ASCAP meeting and read the literature, where hundreds of papers on DNA cytometry as a way to predict the behavior of tumors. That was done with flow cytometry and image analysis. Who does it nowadays? I don't think anybody. So these are examples of technologies that are very popular at one time. They think to resolve everything, yet they disappear. On the other hand, I think there are some technologies that are very helpful, and yet they are not very used for everybody. The best example is failure aspiration cytology. As we saw from some of the presentations, results are excellent. The procedure was actually described on Memorial in the 1920s, so almost like a century ago. But then it's not used everywhere. I think because basically the gods of pathology were not cytology, they didn't know what to do with it. And also the economics are not there. It takes a fair amount of time. It's probably preferable to do 10 polyps than spend the time to do an FMA. But it's a technology that is cost effective and it could be more popular. So not everything according to quality and practicality eventually wins. By the end of the 80s, I was already an attending. And then in medicine, there was a revolution in a sense with the development of the evidence-based medicine movement. This started in Canada by Dr. David Sackler, where basically they realized that many of the things that were done in medicine, they were talking about clinical medicine, were really not true. And basically they emphasize that when you do studies, there are observational studies, and then there are scientific studies with the controls. Observational studies, you look at certain number of cases, for example, and then you see some phenomena, and then you assume that that's the case. For example, you take 100 tumors, 50 behave a little worse than the other 50, bad prognosis. Patients should be treated with chemotherapy. But that's really not the way, for example, nowadays pharmaceutical companies do. They don't give the medication to 80, 100 people and then they sell it. They have to go through clinical trials and so forth. So they show multiple examples of situations where in medicine people were doing things that didn't make any sense. When I was a kid, for example, I had a cold, everybody gave antibiotic. They did studies and that was basically a waste of time. But it was really works. So they emphasized the need to do scientific studies that were clinical trials with controls as a way to really develop scientific information, what they call best evidence. The other concept that they introduced is that they basically, the experience was not necessarily so good. And they had this joke that clinical experience means making the same mistakes with increasing confidence over an impressive number of years. In pathology, this was not very popular for almost 20 years, so we sort of live our own merry life. But the clinicians basically now swear by this, and more important, all the administrators basically go by evidence-based principles when they approve a treatment or they pay for something. So these are examples of the way we do studies and the way it could be seen from an evidence-based manner. This was a nice study, presence of micropapillary as a prognostic finding in patients with stage 1 adenocarcinoma. They had almost 1,000 cases, so very impressive. And then they stratified the cases with micropapillary and no micropapillary, and they showed you that micropapillary is a worse prognosis, which I think everybody repeats nowadays. When you look from the evidence-based standpoint, you can ask yourself, how were the survivors done? Did they consider the clinical stage of the clinical situation of the patient? Some patients may be very old, other people may have emphysema. Did they correct all the things that could influence survival? This is really not a clinical trial that is a control for multiple. Then what did they have as a kind of control to see if this makes any sense or not? And the most important thing for pathology, how do you know if the case has a micropapillary before it's operated? Are you going to determine that with a biopsy or you're going to do that by frozen section? So it's a type of information that sounds very impressive, but then when you look at the details, the clinical validity is sort of not so clear. So these people developed the concept of quality of evidence, and they developed this pyramid. So the worst cases were case reports on case series based on observation. And they basically didn't give a lot of value to observational study, which is not really true, as I'm going to show you in a paper that was published as a joke, as a reaction to this. Then they said the better way would be to do a control case. You have cases with controls, which I think in pathology we still do. But then they say even better would be to do cases with controls and then external controls from somebody else. So you develop a tumor, it's supposed to have poor prognosis, you test it with cases from another hospital, and you see if you get the same result or not. We really seldom do that. And then, of course, randomized clinical trials will be better. And meta-analysis of randomized clinical trials in their mind was the best way to do it. So by early 2000, Mark Wick and I became interested in this topic and wrote this paper in Human Pathology. And we got our 10 minutes of fame. So we got invited to the Association of Directors of AP to give a couple of lectures on this. And everybody was very polite, but nobody believed anything. And I think they probably invited us because Dr. Wick was very well known and a very respected pathologist. But what we attempted to show in the paper was basically that one has to pay attention to the details of studies. So you have to analyze the scientific basis of diagnosis, prognosis, and so forth. And this is like putting your finger in food. Nobody likes that because it's uncomfortable, and it raises uncomfortable questions. It's not very popular. And even things that professors were saying are incorrect. So it didn't get a lot of traction. We also proposed a scale of quality areas. What would make a good study in pathology? And then we discussed the topic of evidence-based versus expert opinion guidelines. So this is a scale we proposed. And in our mind, a good study would be with controls, and then it would be better if the study is done prospectively, and even better if the case would be with controls that are external to your hospital. So you would do it between different institutions. But those things are difficult to do. So how do we do studies nowadays? Analyzing the technology in a way. So you have a group of cases with diagnosis A and B. When you do that, very often if you're studying antibodies, it's not likely that you use some of the newer antibodies before, no? Because you heard or you read in a paper or one of your colleagues in basic science told you that may work. So you have some of the cases already stained with the antibody, but then you collect the cases and do the stain. You select controls, let's say group B, and then you do the statistics, you get a good sensitivity, specificity, you publish that this is a very helpful antibody for diagnosis, and we do that all the time. And then from there on, we recommend that the use of that antibody will be diagnostic of entity A. But what's the problem with this approach? You're using basically circular reasoning. You did a study where you knew the answer, A and B, so why did you need the antibody to be with? And then you got a specificity 90%, which would be very good. That's still lower than 100% when you study. No. So there's a certain amount of circularity. You only probably didn't select all the possible controls for the entity. So in the evidence quality scale, this will be low quality, evidence level 4. So a better way to design the study would be to separate your cases into training set and training. So you will find that the antibody is helpful in your training cases. Then you will test cases where you don't really know what they are and then apply how the antibody works. And then use an external value like, I don't know, survival, for example, to validate where this works or not. And that's obviously very complicated, so most people will be lazy and they don't do that. Even myself, so I'm not preaching things I've done and other people don't. When we look at the studies, we also have to consider the clinical validity. For example, this is another study on napsin in the diagnosis of pulmonary alveolar proteinosis. And you can read this, but basically there were like 20, 30 cases, and they showed that cases of pulmonary alveolar proteinosis stained with napsin, and most of them stained with PAS. So you think, how did they do that? To their diagnosis, they use PAS. Then they stain napsin. They don't show all the future cases where we really had a problem and napsin work. So are you going to believe this 100%? But anyway, these things get into the literature. So looking at these things, you become a little skeptical. But I don't think it would be an impediment to doing research. It would be basically an opportunity to think about these problems and try to improve in the future. But the bottom line is that you cannot believe everything you read in the pathology literature. Studies often don't specify how groups were selected, how things were done. So you need to really read the methods of a paper, not only the abstract, and jump to the conclusions. So the other topic we discussed in our paper was basically the evidence-based versus opinion-based guidelines. And at the time of Dr. Enzinger or Rosai, all the recommendations were opinion. And many of the WHO opinion classifications are opinion. Basically, you have a group of experts, sometimes they're self-appointed experts, and then they usually call their friends because they will get support in the discussion. And then you get into the discussion and you realize that sometimes it's clear evidence against something, but it will hurt whoever invited you. So they're not going to give a different opinion. So there's a mixture of technology, opinion, some hospital politics, rather than all scientific. The evidence-based guidelines are supposed to be different. You're supposed to do systematic reviews. You will formulate specific questions. Then you will look at the literature using multiple databases, not only PubMed. And then you will try to find the answer to the questions. And unfortunately, often the answers are not there, which is good for you because you say, nobody knows, maybe I can do a study to do that. So you will either find good evidence or absence of evidence, and then you will try to get in your mind how good the evidence is, and then try to use best available evidence. So how do you use the questions? In the case of the example I showed you on micropapillary adenocarcinoma, you could say, great, that paper didn't say how am I going to diagnose, how am I going to tell the surgeon where to do a sublobar resection or lobectomy. So you could design a study where you do frozen sections of adenocarcinoma, try to find micropapillary features there, and then see if that works after the surgery is done correctly. And then if that works, you could really use that to tell the surgeon how to stratify patients. But you cannot really jump to that conclusion before the study is done. So that would be a specific sort of targeted question. When you do that, you will do a systematic review. Did anybody look at this? My guess is not, but I didn't do a very thorough review. And then you will try to combine your experience with publish. So this approach initially was rejected, but I think now institutions like the College of American Pathologists are using the evidence-based approach, and they spend a lot of money and resources doing that. They have technical people doing systematic reviews, and then the experts that come up with recommendations basically have to base them on the evidence or lack of evidence, and then they give you an impression, this is based on real evidence, this we're guessing, and so forth. So it's not perfect, but at least it gets a little closer to the truth and to a scientific approach to the problem. Of course, like anything in medicine, this created a reaction, because the doctors are not really looking forward to changes. We're kind of conservative people. So people start complaining that these guys are advocating cookbook medicine. They're doing guidelines on everything. This is not really the art of medicine. And the advocates of this published this interesting paper that you want to be amused, you will be good reading, where they look at the specific questions, do parachutes save lives? And they did a systematic review of the literature, and they couldn't find high-quality papers showing that it's a clinical trial with parachutes. So they advocated that we are not sure if parachutes save life. There should be a clinical trial where the evidence-based medicine people should volunteer to be in the control group. There's irony here, but on the other hand, there's some truth to the evidence-based approach to guidelines. So how we moved from the late 80s, we went through immunohistochemistry, evidence-based medicine was coming into it. So as we arrived at the 21st century, what was the background in pathology? I think there was inflation would probably be the summary works. The more you will do, the better. Doing more tests, more of this. The leaders of pathology were doing research, leaders in the sense of people doing research, not necessarily the department chair, were doing research, studying with all the fancy methods and advocating that whatever they found in their investigation should be used in practice. So you look at the WHO classification of tumors, it's every year becoming longer and more complicated. But then you ask yourself, are many of these categories make any difference in daily practice if you are in a private practice in a small town in Montana, for example? Many of these things are of academic value, so there is a lot of value in understanding reality, trying to define it perfectly, but there is a different dimension of clinical practice. So one of the tenets of evidence-based medicine is that the scientific evidence has to be interpreted on the basis of patient values. And this is something that sounds strange to pathology, but it's not a bad idea to think about it. What do patients care about? If I were a patient, I care, do I have cancer or not? Should I get surgery or not? Do I get chemo? No. Do I care if the tumor is EGF positive? I couldn't care less. Are they going to send me a bill or somebody else will pay? Those are basically the values of patients. And many of the things we are doing for academic reasons are very expensive, so they don't fit into the last part of clinical values. So some people have advocated that we should have two levels of classifications in pathology. One would be the scientific, which is the one we are doing in WHO with some politics. And then there is what is being called managerial classifications, to try to group lesions into clinical categories that will be treated in a different manner. And that approach was used in the past, for example, for lymphomas. They were treated low-grade, middle-grade, and the treatment were targeted in that manner. And nowadays, I think that approach is becoming less popular with the advent of personalized medicine. I will discuss that has a number of potential flaws. So basically, we're doing a bit what I think is pseudoscience. We require to do a lot of details, and then we end up getting more work. For example, you have a breast biopsy. When I was at Mount Sinai, you had mastectomy, margins, tumor, size, lymph nodes. I could sign up the case in 15 minutes. Nowadays, people get multiple margins. You have to paint it, measure the distance to each one, take X-rays. I mean, it's a lot of more work. Or do these things, all of them are clinically necessary or not? I think if you were to analyze this in detail, you might find that some of the things are not really so practical. The same way if you are supposed to classify renal tumors doing all kind of molecules and so forth, you really need it after the tumor was resected. You may think the patient has a poor prognosis, but what are you going to do? You're going to give them chemo without a clinical trial. It's not going to be approved by the insurance company. So many of these things are not practical in the sense of the daily practice. But in general, I think the more we're doing, the more popular in the academic center. And I think now everybody's become specialized in the US. In large departments, everybody's in a different category. And sometimes this works in an ironic way. Like for example, at the higher mind department, the guy that was trained in pulmonary pathology at Mayo Clinic, he's very experienced, then they put him in the breast team because there was a need for that. Maybe 2 years from now, somebody will quit the GU team, and maybe this poor guy will end up in the GU. So some of this specialization creates a lot of logistical problems. So it ends up being imperfect. On the other hand, I think we have laboratory information systems that make many of these we're doing faster. So even though I sound a little negative, pathology is doing great. With imaging and endoscopy, our great friends are sending many more specimens than before. So laboratories like this are booming. Our hospital is increased the volume like 4 times since I worked there. We're hiring more people. Subspecialists are working more closely with the clinical colleagues, so we are not viewed as technicians anymore. We're part of the clinical team to some extent. And I think younger pathologists are less respectful of authority, which I think is a good thing. In the past, the chief was the god and everybody was right. Now I think you have to be careful. For example, you're giving this lecture, and I say that adenocarcinomas are 85% TTF1 positive. Somebody in the audience may pull up the phone, Dr. Marchevsky, this paper says 79%. and then they may embarrass you. So you have to be more careful about the conclusions. And I think this is a good thing. As many of the younger people are very adept at using computerized technology, particularly their phone. And I think it takes less time to do many things. We used to read books which are very thick. Nowadays you look it up in Google and they have the answer in 10 seconds. Although it's not the same depth of information. At the same time, newer technologies are coming into play. So I'm going to go briefly into it. In an hour, you cannot discuss any of this in greater details. So we have a whole slide imaging, molecular classification of tumors, and then artificial intelligence. And in artificial intelligence, everybody thinks of a magical computer that thinks like a superhuman and does everything. And that's used in the field as a general artificial intelligence. And that's a dream that even the experts think is not possible in the near future. But there are like sub-specialties. Voice recognition is one, development of chatbots. There is a lot of interest in generative artificial intelligence. And then the development of intelligent agents, programs that do certain things for you. And that becomes a threat to pathologists. Are these intelligent agents likely to replace pathologists? I think you know more about digital imaging than I can tell you, but it's basically a growing business. There's an article where they show it grows at about 12% a year. They're saying that by 2032 it's going to be a $3 billion industry in the US. You look back, digital pathology is really not a new technology. We did studies in the late 90s. I remember one year we went to ASCAP and my residents had like 5 papers where we had this high resolution camera. Then we could take a photo of the whole slide and then make diagnosis on the computer, which seemed like a magic. And we applied to different organs. At the same time, this company, Bacchus Laboratories, had a system where they divided the image in multiple squares, which was a precursor to the now period scanners. We also could transmit the images via the internet in an email or with an FTP and make a very cheap internet telepathology. But we had no commercial interest, so this is never were developed at the practical level. Later on, they developed these scanners, and then people trying to sell this to everybody. So it's worth considering what are the advantages and disadvantages of whole slide imaging versus a light microscopy. I think the advantages are basically logistical. You can storage and distribute the images very readily. You can practice at a different place, which it could be an advantage or disadvantage. I would like to be in the beach in Malibu and then get cancer there. But some people may prefer to work at home, like some radiologists do nowadays. The technology allows you to put graphical overlays on the image. So you want to measure something, it's very easy. And then it can be used for interactive conferences, which I'm sure many of you are doing. The disadvantage is that these things are expensive. You need a very good fiber optic system to transmit the images. You need very good monitors, rapid computers. You need somebody to scan all the slides, so you need a person doing that. So it's not cheap. And then what is really the advantage for general pathology? Some people say it saves time, other people say no. The general pathologists are reluctant to adopt new technologies unless they have no choice, or the technology has a very significant improvement in quality or efficiency. And as far as I know, nobody showed that this imaging, whole slide imaging has a definite advantage in terms of quality or efficiency, although some of you may disagree. I think in practice this is being used by many as a marketing tool. People want to be cool. And they write papers like this, digital pathology rapidly transforming cancer diagnosis, which I think is not really true. Their papers explain that this has been implemented in many large medical centers and they claim great success. In our department, we're using it for frozen sections between 2 hospitals that we have. We have a scanner that it scans one slide, the frozen section is done by a technologist and what else, and then they show you in the monitor, and everybody hates it. The quality frozen sections tend to be thick. Then the scan is not perfect. Then the person is in the other place, you have to call them. You have the surgeon calling you for the result on a lymph node where there are micrometastases. I mean, it's not very easy to do, but we're being forced by the system, and at least we have imaging, the whole slide imaging in our department. What I think is very helpful is for daily conferences, where you can digitize the slides and show them in a video conferences. So we do that all the time. And we also can use this for teaching. For example, for pulmonary cases, I made a lot of cases that are digitized as a teaching collection. In the past, we used to have teaching sets, and they disappear all the time. People steal the slides, they get lost. You basically need a policeman. One of my colleagues was very serious about it and kept making notes who took the slides and did it. Now I think they are in the computer, nobody can steal them. And then you can easily stratify them by diagnosis. So that's my take on imaging. We are not going to discuss until later on the diagnostic aspects. The other technology has become very prevalent is molecular pathology. And many of you know more than me. In the US it has some problems because it's poorly reimbursed, particularly the professional category. It's quite expensive to do the test. But I think in a way, by using molecular pathology, is returning to the times before I did my residency, where people were interested in understanding the development of disease. When you describe all these variants in various molecules, we are trying to develop an understanding how the tumors develop and how they evolve and so forth. But that's almost like basic research. It's not necessarily valuable in clinical practice. The molecular tests are obviously very important for certain variants that are actionable, where there are drugs that can be used. And that's very popular now in lung cancer. And it sort of raised some logistical problems. Should you order this test yourself, or should you wait for the oncologist to request the test? The so-called reflex testing versus test ordered by oncologists. In our own department, we basically order the test up front, because it takes about 2 weeks to get the results back. And people say that this is too expensive, and many cases are never going to receive chemo anyway, so it's a waste of money, which is true also. But we sort of decided to do this in a reflex manner, which it doesn't hurt the bottom line of our department. The problem that I find difficult in the molecular way is when these things are used for classification of tumors. And now it's become very popular, the concept of molecular classifications. Like we saw nice about brain tumors. This is a paper of gastric adenocarcinoma. You cannot read this, but they claim there are 30 histological subvariants of epithelial tumors. And then they are doing 500 molecules. So how can you design a study with 30 variables and 500? I mean, you will need like 150,000 cases to validate the study. But people do not necessarily consider that. And then they find some correlation with statistics, they propose a classification. So I think the use of these technologies are akin of a rich person that buys himself or herself a Ferrari, and then he doesn't know how to drive it. He's used to driving the car with automatic transmission. Basically, we have all these fancy methods, but then we never consider how to analyze the data in a productive manner with statistics. In general, I don't have time to go into detail, but there are two classes of statistics, the non-supervised methods and supervised. The ones you've seen in this conference are mostly clustering analysis, where not supervised. You give the computer all this data, finds classes, if they're close to each other, they are not different. If they're separate, they are different. They have all these heat maps that look very complicated. You look at them with a magnifying glass, there are red dots here. Not all the groups are so homogeneous when you look at each individual case. So these are not designed to classify individual cases. Then there are the supervised methods, such as classificatory discriminant analysis, neural networks, and others, which it could be designed to diagnose individual cases. But those are supervised. you're supposed to tell the computer this is A or B, put all your data, the machine will do its thing, and then try to approach A or B the best possible way. Once you have the model, you could test it with unknown, will tell you A or B, and then you could see how perfect the model did A versus B. So that is approachable for the diagnosis automatic by computers. All of these are basically statistical machines using different statistical models. So most of the molecular methods, I think, are now being validated by this clustering method. You have all these complicated heat maps. Nobody can read them, at least not myself. And then the statistics are unintelligible because pathologists are not very interested in statistics. That's not for me. So you basically read the conclusions of the abstract and you take that as a fact of life. But that's not really the methodology that is proposed by evidence-based medicine or pathology. And I think you have to be considerate they use a lot of cases to validate the results. And the more variables they have, the more cases they would have need. So many of these results look very impressive. Like, for example, you could find perfect results. These are studies we did ourselves many years ago, about 25 years ago. I had a neural network technology. It was a very cheap program. And then I studied with a friend in Argentina. I was a chief of thoracic surgery. When he heard I had neural network, he was very impressed. So then he sent me cases and he operated, and then we did pathology and the surgical outcome and the clinical status of the patient. And then we developed a neural network that perfectly would tell a patient if we had a complication or not after surgery. So it sounds very impressive. But it's really bullshit because we have about 30, 40 patients. We're not going to apply this to your mother having thoracic surgery. We also did similar studies with methylation, for example. We had a friend at the University of Southern California that had a multiplex system for methylation. And then we could classify perfectly cells of small cell carcinoma versus non-small cell carcinoma. But again, this is not something that you could jump into clinical practice. But when you read current papers, people are sort of doing this. They do all these methods and then they propose this. Maybe they propose that they need a new company and make a lot of money, but it's not necessarily very scientific. I think I get even more complicated. Like these people want to model histology, molecular markers for cancer classification. So great. But then how are they going to get thousands of cases for validation? In these particular cases, they went into sort of public databases. And then who says if the cases in the public bases are really well classified or not? Nobody knows. These are thousands of cases. Then they put them all together from different databases. And then they play with statistics. And then they show you tables like this, which you are welcome to read in detail. Multiple 0.5, 0.2, then you could spend your day trying to make some sense of it. And then they come with a conclusion and say, if you don't understand any of this, you believe the conclusion. So I think when you look at this, you have to remember the old joke, that there are lies, dumb lies, and statistics. So statistics can be used very often to sort of obfuscate the real findings. And I think the problem in these molecular studies is that they're all supervised. And then for supervision, you have to use something that is true, that is sort of gold standard. Now it's called the ground truth. And how do you develop the ground truth? In pathology, very often don't agree with each other on diagnosis. So the way it's been done now is, and I've been a member of some of these studies, mostly as a curiosity to see how this works. For example, we have a friend in Japan that does this in different formats. Basically, they have digital slides. They have a lot of friends in different parts of the world, and then they show you 200 cases or so in the computer, and then you're supposed to give an opinion and classify this or that. And this sounds very impressive. A lot of cases throughout the world. So this is supposed to develop the ground truth. When you look at the concordance rate, it's really appalling. There is a lot of discrepancy. I don't know how they will reconcile that. And that's been shown in many tumors in real studies, where people don't agree on how to classify variants of lung cancer, for example. You get a kappa value of 0.4, 0.2. You get 0.7, kappa value is excellent. But then that means that 30% of the cases or so were not really classified the same by different pathologies. So to get the ground truth for this training of the computer, it would be difficult. So you get into a situation of computers where you say garbage in, garbage out. So we'll see how these things develop in artificial intelligence. The other problem with this is that this will be very costly and it takes a lot of time. So I think that developing artificial models based on molecular for precise classification of tumor may take many years, and it's not likely to be entirely successful. In a way, I think this is pushing us back in time into the evidence-based era, where we're using things by anecdotal experience. Even though we're doing very fancy tests, we interpreted them like in 1970, in an anecdotal manner. For example, we had this case recently in my department. It was a pleural tumor, looked like this, totally undifferentiated. I did all the stains for carcinoma, melanoma, and so forth in a very polite way. Then I pushed everything in our book. None of the stains were positive. So I was tempted to sign out this as a malignant megatoma, but that's not an acceptable term in pathology. So we call it malignant sarcomatoid tumor and then order NGS. And then the NGS, the molecular pathologist called me very excited that he found a melanoma signature in the tumor. So this is a melanoma. I mean, we look at the clinical history, there's no history of melanoma. The tumor was in the pleural. Is this a real melanoma? There's no way to know. The clinician was very happy because they had something to treat. But in reality, the patient has a very poor tumor. It's not likely to do very well. We never know if it was really melanoma as before, or maybe a tumor that shares a melanoma. We had opposite situation. For example, I had a few months ago a case of lung tumor involving the pleural. We always send it for NGS. Then I get very excited email from the molecular pathology. This is a typical mesothelioma. But then you look at the history, there's nothing in the pleural, no pleural effusion, no rind, tumor is in the lung. The molecular doesn't make a lot of sense. So many of these profiles that have been developed in molecular are based on relatively small number of cases. And then when you have these observational conclusions, they're potentially wrong. So I think it's not bad to continue doing it, but I think you have to be aware of the limitations. Okay, so now we're going to the final topic of artificial intelligence in pathology. And this is also supposed to be growing like crazy, so people selling systems are salivating at the growth of this. For example, now like $1.2 billion in the US is supposed to be about 3 billion in a few years. There are different models. The one that is the most helpful is voice recognition. And we've had it in our department for many years, and I'm the only guy using it. But basically it works very well. And for the last 10 years I've been dictating all my cases with voice recognition. Then you dictate the cases, there you finish, you go home. It's much better than using a transcriber and so forth. Other people, they're not comfortable with the computer, I don't know why, but they don't seem to like this as much. These are people developing in the sense of experimental are chatbots and virtual agents and so forth. And there are many papers in the current literature about that. I think you're familiar with the concept of chatbot. All you have to do is pick up the phone and call your travel agent or your bank. I mean, you'll be answered by a computer. Sometimes it's very hard if you're talking to a computer or to a person. So these are programs designed to listen to you and then provide the answers, either oral or by chat. And there are different methods of developing this, mostly using neural networks, what they call machine learning. There are people interested in designing chatbots in pathology to review reports, for example. So it would be nice if you're doing a research project, you have a program that will read all the reports and select the information you need for your report and then save you time. But these things are not available commercially. But maybe a topic that people interested in informatics may want to get into. There's a question of whether these chatbots can diagnose tumors. And these people say they have one that diagnoses disease and even talks to you about the diagnosis. But of course it's very hard to believe. And they probably have a very set experimental model. But I think that's the way they're trying to push the envelope. On the other hand, you see all kind of pompous papers saying that this is the future, this is going to resolve everything, such as artificial intelligence impacts the breast cancer pathology, which I mean, everybody practicing breast pathology is probably doing okay without AI, so this is not really having such a great impact at the time they wrote the paper last year. On the other hand, these methods are useful for screening, such as the prostate diagnosis and breast pathology. We had a very nice lecture on Monday about the use for screening slides for prostate cancer. So this technology is very likely to become more prevalent. But you have to think about it. If a company is going to develop a program, it's not going to develop it for all the soft tissue tumors that we look at today. There's really not enough money for that. On the other hand, they may be interested in things like high volume, like prostate cancer would be perfect, maybe lung cancer, breast cancer. But these things take a fair amount of work to validate the system, then get them FDA approved and so forth. So it's going to progress rather slowly. The later technologies, the generative artificial intelligence, and some people are already writing papers. There's a very nice summary by Victor Brodsky in Archives of Pathology. So people that are interested in the topic may want to read this. It gives you all the technical background and so forth. And this is being used to create chatbots and try to develop models for diagnosis and so forth. Trying to generate imaging for teaching, for example. People are using this to create controls in studies. So you lack a lot of controls, you create them artificially, and then use them as control. You could argue whether this is really valid or not. But there are people theorizing that that could be a way to make studies with controls more easily. So I talk a lot. So I thought that before I close the lecture, it would be fair to ask ChatGPT what he predicts about the future of pathology. Are you going to be replaced by pathologists or not? He says, artificial intelligence is transforming the field of pathology by assisting pathologists in diagnosing diseases more accurately, which is not necessarily true. However, AI is not expected to replace pathologists in the near future. Instead, it serves as a supportive tool, enhancing the capabilities of this medical profession. So you can relax. The ChatGPT is predicting that you're not going to lose your job. Although the joke is that you're going to lose the job to a pathologist using AI, rather than one that doesn't know how to use AI. And I think there's much more truth to that. So are pathology going to be replaced by artificial intelligence? This is sort of the manual interpretation by me. I think you have to consider that predictions by experts are often useless, self-promoting, and very often wrong. I think Niels Bohr was a Nobel Prize. He clearly said that prediction is very difficult, particularly if it is of the future. I think before you believe this, you need to understand, develop an understanding of the technologies that support things that people are trying to sell you in the way of new technology. And as I tried to show you, many things that were touted, like the solution to everything, have disappeared, or they become less prevalent, which doesn't mean that some of them will stick. But I think from your own education, it's important to learn how to distinguish what's likely to be true from not. And if you are eventually becoming directors of pathology, you will end up deciding which systems to buy and not. And for that, you need to have an understanding of the potential and the clinical applicability of different technologies. I think pathology will need to become more flexible, and I think it's not likely that the practice will change from the way we do it. It's not that we just sit in the microscope, dictate or write the diagnosis, get type, and that's it. It will be more complicated with chatbots, maybe, who knows, whole slide imaging, maybe some programs that will screen slides from you. It's very hard to predict exactly how this will work. It's not likely there will be some predictive or diagnostic models that incorporate clinical data with molecular, maybe some morphological conclusions. These models are not very likely to be designed to replicate pathologic diagnosis because it will be very difficult to get studies with ground truth and then to collect cases enough number to make the studies. On the other hand, the computer technology may not need all the different diagnoses. To tell somebody if they are going to have malignancy or not, you only may need to know big cell necrosis, big tumors, small tumors, and put them in the computer and maybe be able to predict diagnosis and prognosis in a clinical manner, much better and simpler and faster than what we're doing today. So what can an old pathologist tell the younger colleagues about the future? To summarize, I think there have been multiple attempts to introduce miraculous technologies to the practice of pathology. The proponents have often hyped their potential, their disregarded prior empirical experience, and they seldom try to integrate the old with the new, which will be more practical. I mean, we have a lot of information that has been proven true, like certain tumors with other prognosis that we share. So when you have a molecular or another method, you don't need to reinvent the wheel. You may try to improve on the old, and if it doesn't improve, maybe it's useless. I think it's important to review the quality of evidence supporting the application of new methods, as validation is often difficult and time-consuming and often expensive. On the other hand, I think it's not practical to hide behind the microscope. I think in molecular pathology, digital imaging have a great potential to change pathology practice for the better. I think for young people, I think it's a good idea to perform research projects applying AI methods. I think you have to get beyond the typical statistics and try to experiment with artificial networks. Now the new technology is transformers. That is the one using Czech GPT, where the computer splits either words or images into small pieces, try to find correlation with the next small piece. And doing this multiple times, it finds images. And that's a technology being used to create artificial images. And you can create different type of images using Czech GPT. Some people have created pathology images of different tumors in that manner. So I think some of these technology may end up being practical. I think it's good for young people to become familiar with this and experiment. And maybe some of these will become practical applications, which are not very likely to be coming from Harvard or the big medical centers, which are run by professors that sort of have their own interests and set in their ways. Many of the new things in pathology were often developed, like in many applications of finding aspiration pathology, where people interested in practical aspects and pushing them. Okay, that's all I have to say. Thank you for your attention. Okay, I think now the professors need to give their opinion. I have several questions. You want me to go over them or just want to do your opinion?
Let me just we decided to do a panel discussion based on the presentation by Dr. Marchevsky and Michal. Don't hide. Please come up here. Paul, we need you here. So we assembled a panel of the people with the most gray hair, so that they can sort of share their opinions and their experience regarding these issues that have been detailed. There was somebody who was volunteering, Volkan Natse, is Volkan here? Or did he run away? There he is. Somebody volunteered you, Volkan. And of course, anybody else who would like to step up and But what we would like to do is we would like for you to interact with the panel and share your concerns, your opinions, any questions that you have, or any observations that you have regarding what you believe is the current status of pathology, its future, and the direction that we're going to be heading. And then Dr. Marchevsky is going to have a question, he's going to ask you questions, and you'll be graded on it.
MMWF, and I have a comment on the presentation. It's just something I came across about 10 years ago. I see a lot in the literature that people try to compare two methods and of course they have this gold standard, and they do this new method. The new method is supposed to be better than the old method, and they compare them, they correlate them, and then they produce a result. And I don't know if you're familiar with the Altman-Bland method designed in the 80s. They say you should take the gold standard, the new method, add their values, divided by 2, and then compare with the new test. And then you get much more appreciation of the true result. So this is something that I see all the time in almost all the papers. Nobody is doing this, but they should. If they really want agreements and not just correlations between 2 different methods. Thank you. And thanks for your wonderful presentation, Dr. Marchevsky.
I think part of the problem that people that review papers are guys like me, they don't understand that this is a support. They're busy doing something else, so they're going to look at all the things.
I would just step into the discussion. I would like to, let's take back 10 years ago when I was moving here, yeah, and I realized how the things are changing when I found all my boxes, many of them from the old department that I found still being closed here, and I'm opening them because I have some interesting cases from the past. I don't want to throw them out, but I found tons and tons of diapositives, and now my whole life is in one flashcard. It's a progress. Yeah? I would say 10 years ago. Yeah? Otherwise, I am not surprised about the progress like that. It doesn't surprise me that. Maybe this is not, for me, this is not the biggest help with the course of time. I remember when I was young and when I did research, going to the library and going through that, yeah, it was progress then, that you have open Medline, whatever. The progress of these days I consider just normal somehow without any surprise. Yeah. Maybe I'm too old to say that my biggest progress were in the past, not now. Yeah. And we play this artificial intelligence and we just think that it's nice child play. Yeah. It's really people, especially men and children till advanced age who really like it. You know, but, I didn't prepare for that because I thought that the panelists will be my son. Yeah. So the chair just tell you when somebody says about progress, I feel my biggest progress in life. Yeah.
Yeah, I think this was a great presentation, really summarizing so many things and very nicely historical. One thing I have about concerns for the next generation or current state is information is so fast and so accessible, but the accuracy, of course, is a different question. I think that's something I see a lot with the young generation, looking at the social media posting of cases which are not vetted, and some of them are really grossly inaccurate. And publications, the good old journals have at least two reviewers and editorial. So there is some degree of, for better or worse, reliability. Whereas in the current state, a lot of the information, like the testing you were mentioning earlier, a lot of the information is unfortunately coming through unvetted sources. And the young generation doesn't seem to really appreciate that. It may not be reliable, they take it for granted. So there's one, I think, angle that I thought will be interesting to discuss in this platform. And a healthy dose of critical thinking and skepticism is will be very important moving forward. My 2 cents.
I understood that this discussion is going to be about predicting the future, which is obviously impossible. And I am at age 85 getting very skeptical about so-called plans. If you look at the history of World I, War II, War, Afghanistan, Iraq, all this major minds getting together, making big plans, and all this being nixed in a couple of days or so. So I don't think that we should make too much plans for the future, and I predict that most of it will be done by following the motto of Nike, just do it. I think that this institution that Michael has founded here, a couple of borrowed money, is showing that this principle still works. Just do it. And I will add a couple of words that I cannot say in public, but just do it. And okay?
I have actually nothing intelligent to say. I will repeat what Niels Bohr said, which means it's very difficult to prophesy what's going to happen, particularly if you're talking about the future. If you're talking, I'm not a molecular pathologist, and most of that is over my head. I'm an old-fashioned surgical pathologist and cytopathologist who is on his way exiting the scene. Nonetheless, the presentation given by Robert on Monday showed me that with the use of artificial intelligence with a coloration for those prostate biopsies, for those who are here may remember I asked him, when there is no coloration, do you still bother to pick up the glass slide? Because supposedly there is no cancer there. And he said, yes, I still pick up the glass slide. So what I see there is the AI is another tool. The way immunohistochemistry is another tool. The way next generation sequencing is another tool. But this all has to come together, be brought together with a bottom line being the human being, the pathologist. And when I I gave my unknown sessions to my residents, I said, listen, you must act like a physician, not a morphologic technician. You are not only making a diagnosis based on the morphology, the immunohistochemistry, the molecular studies, but this has to fit with a clinical scenario, with a radiologic interpretation. So a lot of these pathologic diagnoses are not strictly morphologic diagnoses. These are clinical, radiologic, pathologic correlation diagnoses. And that's the way I've approached my practice to both cytopathology and surgical pathology.
That is a very interesting perspective. All the people who are sitting up here in this row were brought up and trained in an era of H&E pathology. We were all trained as morphologists primarily, and over the span of years that we have been practicing, we have had to slowly adapt and embrace all of the different waves of technology that had come about. But the interesting thing is that we're a generation that was brought up with a gold standard. There was always a gold standard that guided us in evaluating whatever was out there, and that gold standard was the morphology. It was the H&E. And what I will dare predict for the future is that the gold standard could change. It could get to the point that we won't have a choice other than to embrace different gold standards as we become more technified, as things become more sophisticated, as new technology becomes cheaper and faster, to the point where we may be making molecular diagnoses in the future and throwing away the H&Es. It will not be the ideal situation. I think that would be a mistake, but I think it's going to happen nonetheless, because we will all adapt ourselves emotionally and psychologically to the new gold standard. We will believe it. This is very much like religion. You know, we're brought up with it from our youth, from our infancy. We believe it. We don't question it. It just becomes part of our universe and our lives. And we just embrace it and accept it, whatever the the beliefs may be. And it may come to the point that we will be so firmly convinced and have this belief that whatever this new technology will be, because trust me, there's going to be more than methylation and next generation sequencing. There's going to be next generation methylation, next generation sequencing sometime soon. At some point, we will have drifted so far apart from our roots, from the origin of where we started as a specialty, that cellular pathology will essentially disappear and it'll be genetic pathology or some other type of. What do you think?
I have one idea that will really show that there is big progress coming. Now we are dealing with one company from Taiwan that we will adopt their artificial intelligence software for reading cytology of lungs. And we spoke with our pneumologists that this software can very easily distinguish the adenocarcinoma from other tumors. Yeah? And we will do it from LBC, the same system like Marchevsky for cytology of cervix. And if we found out that there is a adenocarcinoma, what we have in cytology, we will easily to do even genetics on it. And we will treat patients without any biopsy. Just what AI told us, it's adenocarcinoma, and the mutation, targetable mutation translocation, and we will evade biopsy of the patient. Yeah? So maybe it's just one of big leap forward that probably awaits us a few months from now. Yeah? And our pneumologists are really amazing because they say now about oncologists that cytology is a dead topic in pneumology, and it would revive the whole thing to do.
I don't know if you're supposed to make more comments. I mean, just regarding what you just said, I've seen cases actually where they do genetics in peripheral blood of, like, let us say, EGFR mutation in lung cancer, and there's no cancer in the patient. So there's also 4 positive results one has to take into account. And I just wanted to share something completely different. I came across about a year ago, there's this tool from Google called Notebook LM, where it resumes a PDF for you in like a chat or like a podcast of 2 people in a couple of minutes. Or, I mean, the process takes just like 1-2 minutes, and you get some kind of sound for like 20 minutes, like a podcast. And I started using it, and on the way to work and on the way back, I really read or listen to 2-3 papers, and then if I really be interested in the results, then I go and check the paper. And this has increased a lot the number of papers I'm reading. That I can really recommend. I've checked it, maybe I've listened to 500 now, and it's very accurate, and it's for free. So
yeah, but you spoke about liquid biopsy from peripheral blood, but we speak about aspirates from the tumor, yeah?
I understand.
And now that it's not false positive results.
I'm just saying, keeping in mind the false positives. Yeah. Notebook LM.
Maybe one comment about Dr. Schuster's, of course, prediction for the future is hard. Molecular and genetics, of course, is going to be a key role, but we also have to remember, still, I'm a believer of morphology, in the sense that what we see in morphology is a snapshot of a constellation of genomics, proteomics, transcriptomics, and many other omics at once. There are things that one gene may not tell because the other things interfere. Now once we cannot explain things with the genetic alteration, now we blame it on epigenetics. I'm sure there'll be epigenetics that will explain the other alterations. At the end of the day, I think morphology still provides tremendous amount of information, but it clearly is not going to be the sole bearer of the final diagnosis. A lot more will be complementary. This is what I think is the direction.
I would agree that, I compare learning pathology as something that you have to go through, and like you have these atonal musicians who are composing something who started as classical piano players. So in order to get to atonal music, you have to first go through the schooling as a classical pianist. So we are teaching students from the beginning classical morphology, and I think that the student-professor relationship will sooner or later cause a revolt. First it's adoration, and after that you realize that the professor is full of bullshit. And that's, I think, very helpful for them to find their own way to the so-called truth. You know, each of us has different ways, and I think that everybody should do it his own way. My most successful student was the guy who was having a psychological crisis every 10 to 15 minutes. So I told him, listen, why don't you go into the mountains for a month or so, cool down and come back. And then, you know, that's the best advice that I gave him. And it had nothing to do with pathology. So I always say that the best advice comes outside of the thing that we consider to be the gist of our lives. So listen to other people.
This gentleman had a question over here.
Thank you. There is a rift between high-income countries and about 1 billion people benefiting of those developments we are talking today. But there are 3 billion people living in low-resource countries, which just live in a situation with the gap between the technology and classification and treatment in medicine approach getting larger and larger. We are seeing in molecular classification of endometrial cancer, the development goes in a way that most of the people cannot benefit and cannot do classification because the figure 2023 is somewhere else than the reality of those medical systems. So, from this point of view, what do you think this rift with applying novel technologies will act in those 2 different fields between those 2 different populations?
I come. Oh, somebody else. No, I'm originally from Croatia, and if you look at the statistics and all this, Croatia has a very good health system, but in practice it is kind of far from that idealized statistical. On the one hand, we have an excellent transplantation program. I think that statistically we are on the 1st or 2nd place in Europe when it comes to liver, heart and kidney transplants. On the other hand, the overall health care, if you look at the statistics of the World Health Organization, we are on the 38th position in the world. So a big discrepancy. On one side you have something that is really excellent, on the other hand overall income and all this. And the same is true for pathology, you know. So my major problem that I see in Croatia is how to attract better people to go into pathology. And I would like to ask our host today, you know, his success is in part his own mind and drive that he has, but he would not have accomplished this without having good collaborators. How do you find good collaborators? or translating that to the medical school situation, how do you try to recruit the best students to go into pathology? Michael, tell me. Michal, how did you successfully put this thing together?
Actually, I must say that we have, I do not see myself any young pathologist in our country to offer the job, I don't see any. So they disappeared. I remember with Dr. Zamichin, he is nearly retired, 25 years ago, that when the times come, how many young pathologists, especially with the fall of communism, would be loving to do pathology, but I guess that all interesting people we could get, we already have. They came, but now, for the time being, I don't see anybody, so that we decided to get more medical students because owing to our position, medical faculty, there is a big interest of Pilsen medical faculty for young people to come here, but I do not see the same interest elsewhere. We had a very sad thing in faculty department that 2 people died there, including Ondrahes. One Russian guy disappeared with the first day of the war. One left the lab, maybe solving his problems in marriage. 2 ladies found out that they would be too work, so that they came to forensic medicine. The whole department, medical faculty, is in the breeze. There are 5 people left, for 300 medical students, for all of this done. And I'm a director, I told him, I do not know how to solve it, We just promised you we wouldn't let Pilsen medical faculty to fall down. We are doing it on the remote access, that our people have some not big money to do it, but I am quite skeptical. I do not see big interest in high quality people, and the only one I hope we get now, these few students are about to start to work with it. We have some 6-7 medical students that come to our department within the coming years. We even employ these medical students for grossing now. They have senior grosser looking over them, they are grossing so that they wouldn't have to do any other job to get money, but otherwise I am very skeptical about it's very difficult work. Who can spend the whole life hidden behind microscope, with one leg in a suit, or to be in lawsuit, whatever. So who would do it? It's much easier to earn money elsewhere nowadays. So I have not answered for the question, and I'm skeptical.
I give the example of Messi. You know Messi? He was 12 years when somebody spotted him in Argentina that this guy has potential. So I always say that an optimist is a 95-year-old man who is planting an apple tree, hoping that he will have the opportunity to try the apple, eat it. So I'm 85, I'm optimist. I think that we should be going around and recruiting people into pathology. I mean, that's the only way to survive. Our specialty has so much to offer, but it's a big secret because in the United States, pathology as subject has been eliminated, so they have no exposure. The statistics show that of the 130,000 medical students who graduate every year, 123 go in pathology. That's trivial, right?
I want to thank you all for your participation. Before we conclude the session, I would like to narrate a little bit for those of you who are here who are not familiar with the Arkadi Rywlin Club and what we're about and how this came about. just a few words so that you understand who we are and what we do. Dr. Rywlin was the chief of pathology in Miami, at the Mount Sinai Hospital and the University of Miami. And I trained with him. I was his resident. Dr. Rywlin became famous as a hematopathologist. He wrote the first textbook of bone marrow pathology. And he was a very special kind of pathologist and great teacher. In 1990, when I finished my residency and all my training, I was hired back at Mount Sinai Hospital to start practicing pathology. And that's when I decided to start the club and named it in honor of my teacher, Professor Rywlin. And this is the original letter that I wrote. It's only part of it, but I want to bring to your attention the purpose of the club is to carry out an active exchange of interesting, unusual, or challenging cases in diagnostic pathology on a regular basis among its members. This exercise is meant to be conducted in a non-competitive and friendly spirit, with a view towards sharing and broadening our knowledge and experience in the different aspects of anatomic pathology. There was a very special reason why that sentence was included in there. We were brought up in an era that was extremely competitive, where everybody was trying to outdo everybody else, and everybody was in competition with everybody. And what I wanted to accomplish is get together a team of people who would not be in competition with each other and who would become friends and would be bound by their common love of surgical pathology. And I'm very happy to say that we were very successful in doing that. This is the Arkadi M. Rywlin website, which is courtesy of Professor Michal. He's the one who hosts this website and created it. Here we post all of the seminars, the opinions of all the members regarding all the cases that are being exchanged. There's even photographs of activities of the club. But perhaps the most important part of our activities is the fact that we decided to bring this to a general public and started these international meetings, which are rotated in different countries, so that we can share these interesting and challenging cases with other people, and at the same time feed off of each other by hearing everybody else's opinions. And one of the interesting things about these seminars has been that some of the most interesting discussions and questions that we have received regarding the cases being presented over the years have come from the other members of the club in attendance, who will ask us to clarify some of the opinions that we have. We've had a long run. It's been more than 30 years, 33 years to be precise, that we've been running the club. We started the first international meeting was in 2002 in Italy, San Giovanni Rotondo, and the second one was here in the Czech Republic. We've been to Australia, to Slovakia, to Tokyo, Japan, to Croatia. But the most important part, as far as I'm concerned, I'm here speaking for myself, what has been the most endearing aspect of these meetings has been the camaraderie, the joy of getting together as friends, not as competitors, but as colleagues and friends, and to be able to spend time with each other, bring our families, get to meet new people, experience new things. This is from the Czech Republic. I don't know if this pointer is going to work. Well, here. Look at this. It looks like a cowboy in a cowboy movie, the hero. this is what we used to do at these meetings, just get together. This is Dr. Hugo Dominguez, hosted a meeting in Mexico. And here's a group in Mexico. This was Istanbul. Where's Volkan? Does he recognize this? Here's again the picture. This was Copenhagen. We have the Stockholm. I'm sorry. And this is the group that we had hosted by Joran Melberg. I brought just a few examples of the activities that we've had over the years, but essentially, we love surgical pathology. We love life. We have enjoyed these meetings. It has been my privilege to be able to share my career and my experience with this group of people who have been just simply amazing. It's been an honor and a pleasure and a privilege. Some of us were here. For some of us, this may be the very last meeting that we will be attending. We are now turning it over to the next generation. David and Michal will come up here and say a few words to close the session. But I hope that the club will persist, that the new generation will be as enthusiastic as we were, as our group was, in getting together and sharing experience and discussing cases and being excited about it, and also in having as much fun as we did. We are going now to hand out the two prizes. Is Delia here? The first prize for the competition, which I'm sorry to say, we have a group that was not very brave. Not too many people turned in their diagnoses, but Eric Wittersand. And I don't know where. Thank you. Good. Okay,
So, thank you. And the second prize, because we got only two attendees, so thank you very much. And the second one will be Zlatko Marušić, so probably.
Michael Jr. Is he here?
Michael Jr. is now serving his father and mother with grandchildren, so that I should, it is a place to go down.
David, come up here.
Sure. Okay, thank you. There's not really much else to say after everything
we just heard a few minutes ago. I just want to sort of close out the session by saying thank you to everyone who attended the conference, to all of the faculty who gave presentations, and of course to Professor Michal and his laboratory, and Christina and Marion and everybody who helped direct the course and helped organize all of this, and gave us the opportunity to host another AMR. So thank you all so much for coming. I appreciate it, and like was mentioned, hopefully we'll have a new generation with new members and be able to continue this into the future. And 25 years from now, it'll be me and Michael Michal standing up here retiring and passing it on to somebody else. Thank you.